Great. Yeah, well, thanks so much. And I don't know if you did this on purpose, Jeremy, but it's Women's Day tomorrow. So in celebration, we're going to be talking about maternal and fetal infections. And as Jeremy has said, it's obviously quite a large topic. So it's quite difficult to know what to concentrate on. But what I'm going to do is give just a broad overview of maternal and fetal infections. I also want to look a little bit into maternal fetal immunology, although Lauren did give us also a bit of a primer when she was talking about maternal immunizations. And then I'm going to look at congenital infections and chorioamnionitis. So infections during pregnancy can be associated with devastating consequences, both to the pregnant mother and or the developing fetus. And we know that infections in the mother can be more severe than in the general population. And we've seen this with influenza, with H1N1, for example. Pregnant women were only 1% of the population in the US, but they accounted for 5% of the deaths. We also have seen with COVID that pregnant women often did much worse than women their age who weren't pregnant. And you know, some conditions such as urinary tract infections or wound infections are going to affect the mother more than the baby. But the mother and baby are actually quite closely entwined, and even urinary tract infections are likely to result in premature labor in the baby. But there are some disorders that are mainly going to affect the baby, such as, you know, herpes or CMV, group B strep. And, you know, the ones that affect mom and baby together, things like HIV, Choreoamnionitis, syphilis. So as I'm a pediatrician, so I'm going to be concentrating mostly on pediatric or the fetus. But just to remember that maternal infections, the leading cause of maternal morbidity and mortality in South Africa is actually non-pregnancy related infections. And if you look at this huge chunk, it's the majority of the causes of death in pregnant women, and we mustn't forget that. And then also puerperal sepsis and septic miscarriages, pregnancy-related sepsis are another quite huge part of the cause of maternal mortality. And I think, you know, ideally we should be encouraging all women to plan pregnancies and to know their HIV status before falling pregnant. And thankfully, we have seen some, you know, improvement in the maternal mortality rate, but it is nowhere near what we want with the SDG goal of 70 per 100,000 by 2030. And if we look, what has contributed mostly to the improvement is actually ARVs. So if we look, ARVs introduced in 2004, and then by the time we get better coverage, we are drastically decreasing the amount of mothers dying in pregnancy, usually as a result of complications from HIV. But you can see that it is still the #1 cause of deaths. And then when we look at neonatal causes of death, prematurity really is a large chunk. It's 49% of it. And, you know, we need to understand what is driving prematurity, you know, why do we have so much preterm labor in South Africa? And anyone who works at Rahima Moosa will say our prem wards are continuously overcrowded. And obviously, you know, it's driven by poverty, food insecurity, and malnutrition, things like smoking, HIV, TB, chorioamnionitis, even STIs. But it is thought that bacterial and or viral infections are responsible for up to 40% of preterm birth cases. So even, you know, in the causes of neonatal deaths, it could be infections in the mom. So how does a baby get infected? You know, it can obviously occur during pregnancy, and that would be, you know, hematogenous usually, or it can occur at the time of delivery. That's, you know, classically we think of hepatitis B, HIV, or it can occur postpartum with breastfeeding. So just graphically to look at this, you know, the mother can get infection, and then it can spread hematogenously and then have impacts on the fetus. And the fetus can result in death of the fetus with miscarriage, abortion, stillbirth, or it can result in, the growth restriction or congenital malformations with the baby. And the baby could still, survive, and there could be late sequelae to that infection, or they could acquire infection at the time of delivery. So the placenta restricts vertical transmission during pregnancy and has actually evolved robust mechanisms of microbial defense. And the microorganisms that cause congenital disease have likely evolved lots of different mechanisms to bypass these defenses. If we look at the structure of the maternal fetal interface, it includes the maternal side, the maternal decidia, and the fetus-derived placenta. And the trophoblast cells are fetally derived cells, and they are one of the major orchestrations of immune regulation at the maternal fetal interface. And they can actively create an environment that actually promotes a tolerogenic phenotype so that the fetus is tolerated and not rejected. And in addition to that, these trophoblast cells are able to sense and respond to PAMPs, or pathogen-associated molecular patterns, that are present in microorganisms. But overwhelming infections can disrupt this maternal fetal interface and can lead to pregnancy complications such as chorioamnionitis and preterm birth. If we think about the transmission of HIV, it also gives us some understanding of the job of the placenta. So the most inefficient way to transmit HIV is actually in utero. And without ARVs, only 5 to 10% of transmissions would occur in utero prior to birth. Most of the transmission occurred at birth. So how can a baby be infected? They can be infected transplacentally, and pathogens such as Listeria, CMV, or Toxoplasma are able to cross the placental barriers, and then they replicate in the placenta and eventually infect the fetus. And then at the fetal level, microbial tropism for fetal cells may account for specific teratogenic consequences. And the good example of this is Zika, which has tropism for fetal neural cells. The placenta can also be disrupted at the time of delivery, and you get fetal maternal hemorrhage, and you get vertical transmission then of hepatitis B, HIV, and other viruses. And then ascending infection from the vagina often occurs with rupture of membranes and results in chorioamnionitis. And then the infections in pregnancy can affect the maternal host, the fetus, and or the placenta itself. And the results of infection and the inflammatory response have consequences at each site. So, the inflammation can actually cause problems in the mother herself and can result in death or sepsis. Infection and inflammation can affect the placenta, and you get placental insufficiency, and inflammation in the mother or infection of the baby can result in growth restriction or intrauterine microcephaly, and the baby can even die. So vertical transmission is defined as infection of the fetus from the maternal host, and it's a major cause of morbidity and mortality in pregnancy. And the sequelae of infections in pregnancy also include teratogenic effects, and they can cause congenital anomalies and growth restrictions, stillbirth, miscarriage, and neonatal death. And congenital anomalies are present in about 3% of live births. And we're not sure the proportion of these congenital abnormalities that are due to infection. And 20 to 30% of all stillbirths are thought to be due to infections. But this might even be more because there's such a low rate of diagnostic testing for infections in pregnancy. And the rate of pregnancy loss is variable with gestational age at infection and also with the pathogen. So, for example, with syphilis, up to, it can cause fetal death in up to 50% of cases with primary or secondary syphilis, whereas something like parvovirus is only going to cause pregnancy loss or stillbirth in less than 3%. So just to look at the immunology of pregnancy, we were always told that pregnancy is an immunosuppressed state, but that's largely incorrect and simplistic. And if we compare antigen presentation in transplants, tumors in early pregnancy, you actually see that pregnancy is actually a more tolerogenic state and is actually more like tumor immunology. So this is a kidney transplant. Following kidney transplant, the donor-derived dendritic cells from the graft can migrate to lymph nodes, and they present high levels of antigen to the host T cells. This causes expansion of the affected T cells and results in rejection of the transplant. With tumors, there are low levels of antigen uptake by dendritic cells and gradual presentation of the tumor antigens to T cells. And this can actually lead to deletion of your effector T cells or induction of regulatory or Treg cells, which cause the host to become tolerant to the tumor. And antigen presenting responses that occur in early pregnancy are actually similar to responses that occur during tumor micrometastases. So during early pregnancy, you get low levels of antigen with gradual antigen presentation. This results in deletion of effector T cells and Treg cell induction, and you get tolerance of the foreign fetus. So what we are understanding now is that pregnancy is more a continuum. And in the first trimester, pregnancy begins with a pro-inflammatory environment that allows implantation and placentation. And then it shifts to an anti-inflammatory stage that allows fetal growth in the second trimester. And then finally, just before birth, there's a pro-inflammatory stage that promotes labor and delivery. So inflammation has always been thought to cause abortion, preterm birth, and even preeclampsia. And actually, that is true if you get inflammation in the second trimester. It can result in premature birth. But there are times in pregnancy where you have more of a Th1 response. All right, and then I just thought, this was quite interesting. There is this new thought that the trophoblast cells, which are fetally derived, are actually responding to the normal uterine microbiota. And we now know that the uterus is a normal microbiome, and the bacteria there present their lipopolysaccharides to the TLR4. And this pathway actually causes interferon beta to be expressed by the placenta, which actually promotes tolerance and receptivity of the pregnancy. And then there's this double hit hypothesis. There's thought to be a double hit hypothesis that when you get a viral infection, this actually inhibits your type 1 interferons, and this causes an inflammatory response and preterm labor. So if a viral infection is able to reach the placenta, it's going to inhibit these type 1 interferons and cause preterm labor and other problems. So the thinking is that viral infections abolish the beneficial effects on the commensal microbiota. And this can have effects on the developing fetal brain, immune system, and lungs. So if we look at Zika, for example, because there was an outbreak, it was quite obvious that the Zika infection resulted in microcephaly. But if it had been endemic and only a few people got first infection in pregnancy, we might not have actually realized the cause for the microcephaly. And it's possible that there are other clinically silent viral infections that may be causing fetal morbidity that we are not yet aware of. So, for example, maternal immune activation is thought to increase the risk of fetal developmental problems, such as autism spectrum disorder and schizophrenia, and has also been linked to the development of allergies and asthma. So, you know, after, for example, the 1964 rubella pandemic, or when there've been outbreaks of influenza, measles, mumps, chickenpox, and poliovirus, there was an increased incidence of these neurodevelopmental disorders. So the occurrence of maternal inflammation as a result of viral infection during pregnancy can affect several aspects of fetal brain development. And so that is quite an interesting theory. So I'm just going to look at the congenital infections. And if you really want to upset a pediatric ID doctor, you will request one of these, a torch or a storch screen. We'd rather that you look at the clinical syndrome and request the more likely infections. But just to give a bit of history, where does torch come from? So in 1971, this acronym was proposed by Andres Namias, and it was to denote the 4 congenital infections that are sometimes difficult to distinguish. So Toxoplasma, Rubella, CMV, and HSV. And then in 1975, Harold first decided that it was fairly obvious they'd left out syphilis. So he decided to change the acronym to STORCH because it was German for stork, which he thought was particularly suitable in the perinatal period. And then a year later, someone said, no, it's too confusing. You must call it torches. So it gets all very confusing. And now there's a suggestion to call it torches clap, in adding chickenpox, Lyme disease, HIV, and Parvovirus. So Lyme disease, I hadn't heard of as causing congenital infections, and apparently there's actually no accepted or well-described congenital Lyme disease syndrome. It's because it's a spirochete. They thought syphilis causes such obvious illness in babies. Lyme disease would be likely too. But subsequent studies have not supported an association between Lyme disease in pregnancy and adverse fetal outcomes, and that includes congenital malformations and cardiac malformations. And then we keep adding new viruses. So yeah, the acronyms we don't like. They can help you to remember, you know, what pathogens to look for, but then try and look at the clinical picture rather. So when we look at congenital infections, we look at the mother getting maternal infection and causing bloodstream invasion. And then there are one of 3 outcomes. Either you get placental infection without infection of the fetus, and evidence of placentitis occurring without fetal infection has been shown, you know, with maternal tuberculosis, even with syphilis, malaria, CMV, rubella, and with mumps vaccine virus infection. And the reason for lack of spread to the fetus are unknown, but it is thought that there are defenses of the fetus, you know, within the trophoblast and the placental macrophages and locally produced immune factors such as antibodies and cytokines. And then you can get fetal infection without overt infection of the placenta. That's, you know, when that's usually less likely. And if you look hard enough at the placenta, you might find small areas of placentitis. And you can get the mom having a severe infection, but actually no transmission of infection to the baby. And I think you see this quite commonly, you know, if the mom has bacteremia from meningitis or pneumonia or whatever it is, usually the fetus is protected and they don't get that same infection. And then we see that even if the fetus and the placenta aren't infected, there is effect on the baby and without direct microbial invasion. And this could be from inflammation, the fever, anoxia, circulating toxins, or metabolic and hematological derangements in the mom. And they can even result in abortion, stillbirth, or premature delivery. And the association of maternal UTI with prem labor is well studied, and we're not exactly sure how, even asymptomatic bacteriuria can lead to low birth weight deliveries. And it's thought that maybe you get an altered maternal genital tract microbiome, and you get dysbiosis-associated preterm labor. So if you get infection of the fetus and the placenta, that microorganisms can disseminate and can be aspirated by the fetus, and this can result in death, either embryonic death and resorption, abortion, or result in a prem baby or a term baby. And it's not sure, with embryonic death and resorption, various organisms may infect women in the first few weeks of gestation and cause death of the embryo, but we're not really sure of how many early pregnancy losses are due to infections, because it can be quite difficult to diagnose that. So with prematurity, the same organisms that are commonly responsible for prematurity are also responsible for stillbirth. And previous studies have shown that, women have pro-inflammatory cytokines in the amniotic fluid, like interleukin-6. And there's also known that uroplasma and mycoplasma or bacterial vaginosis during pregnancy can also cause prem labor. All right, and then infection of the fetus can result in developmental anomalies or congenital disease or a normal infant, and either the baby will eradicate infection and have no apparent disease, or they'll be left with sequelae of the disease, such as brain damage or cardiac abnormalities. And then there's some infections such as CMV and rubella, which continue to cause tissue damage after birth and can result in deafness or even death. So just to look, these are the organisms that are usually associated with prematurity. I think the asterisk is saying that the association of effect with infection is still under consideration, but I think most of us agree that uncontrolled HIV is associated with prem deliveries. But you can see TB is another big one, listeria, and malaria. And IUGR, classically we think of CMV, but it's also with varicella and rubella. Developmental anomalies with CMV, rubella, varicella, Coxsackie. And congenital disease, so you can see how our tortoise clap doesn't cover all these others one. And then the persistent postnatal infection, I mentioned CMV and rubella, but there are also other ones that can cause persistent infection. Okay, so I just want to go through a few of the congenital infections. Obviously, we're not going to be able to cover everything, but just to give you an overview. So if we look at what are the standout features of congenital toxoplasmosis, there is this triad of Syphilis, intracranial calcifications, and chorioamnionitis. And congenital toxoplasmosis usually occurs when a woman acquires primary infection while pregnant. And usually the mother is asymptomatic, or she might just have lymphadenopathy, but often she doesn't even know that she's been infected. And if she's untreated, so in the first trimester, about 17% of untreated maternal infections will result in severe disease. Whereas untreated maternal infection in the third trimester, more fetuses are infected, up to 65%, but usually the disease is milder or inapparent. And then if these babies are not having severe disease at birth, you might not even notice it, but almost all these babies will present with chorioamnionitis by the time they are teenagers. And the infection, as I'm sure most of us know, is from ingestion of the oocysts from cat litter or the tissue cysts from raw undercooked meat. So congenital rubella can lead to death in utero, preterm delivery, or congenital defects. And classically, it's the deafness, which is often a late manifestation, cataracts and cardiac disease, which are the classic manifestations of congenital rubella. So the cardiac manifestation is usually a PDA or pulmonary stenosis, and cataracts are only present in up to, in about a third of children with rubella, congenital rubella, so not all of them may have it. Other eye abnormalities can be glaucoma, and they get this classic retinitis called salt and pepper retinopathy, which is caused by a disturbed growth of the pigmentary layer of the retina. They also get this metaphysitis, which looks like a celery stalk, if you've got a good imagination. And they also get intracranial calcifications. And just remember, late manifestations can be things like diabetes, thyroid disease, and growth hormone insufficiency. And then CMV inclusion disease is the most common cause of congenital infection in the world, with about 0.5 to 1% of live births. But in South Africa, it's 2.5% of all babies who are born have congenital CMV. And if they're HIV infected, that can even go up to 5%. And CMV continues to damage organs up to and even after birth. But classically, and they can develop hearing loss, which can only be detected later in some cases. So they'll present with jaundice and hepatosplenomegaly, like almost all congenital infections, or can have a blueberry muffin baby, which is extramedullary hematopoiesis. And the classic thing about them is they get these periventricular calcifications. So the calcifications in toxoplasmosis are not around the ventricles like this, but they can also cause brain malformations, cerebellar agenesis, and other things like that. And then congenital herpes simplex virus infection is actually really quite rare. It only occurs in about 1 in 100,000 to 1 in 300,000 births. So you're more likely, the baby's more likely to acquire herpes simplex virus at the time of delivery or postpartum from the mother. But if they get it congenitally, then this is what they look like. And the characteristic triad for HSV is the skin vesicles, the eye damage, and the central nervous system malformations. And so they have vesicles and scarring, and the neurological manifestations, they get intracranial calcifications, and they also can get white matter abnormalities. Eye involvement, this here is showing scarring of the retina, and they can get microphthalmia, cataracts, chorioamnionitis, or blindness. And congenital infections are described throughout pregnancy and after both primary and recurrent infections, but are most likely to occur with a primary infection, and are most caused by HSV2. And the manifestations probably result from destruction of the normally formed organs rather than from defects in organogenesis. And then these kids, I think differentials, incontinentia pigmentia can look a bit like this at birth, but they won't have the brain involvement. So congenital intraviral infection is something we don't often think about, but they usually babies acquire the infection from the mother, and up to 60% of mothers of infective infants report having a febrile illness during the last week of pregnancy. And so the babies usually present within 3 to 7 days of birth. And systemic intraviral disease typically occurs in one of two characteristic syndromes. So neonatal myocarditis, and that's often accompanied by encephalitis and sometimes hepatitis. And that's characteristically a manifestation of group B Coxsackie infection. And then fulminant hepatitis can present with, like severe sepsis, hypotension, profuse bleeding, jaundice, and multi-organ failure. And the outcome of neonatal infection is strongly influenced by the presence or absence of passively acquired maternal neutralizing antibodies. So, when did the mom get the intravirus infection, and did she have enough time to produce antibodies to protect the neonate? So I think likely we miss almost all of these babies and call it congenital, early onset neonatal sepsis, for example. And then syphilis, I think we're all quite familiar with syphilis, but syphilis is transmitted to the fetus transplacentally when the mother gets spirochemia. So when the spirochetes are in her blood, obviously the baby can also acquire syphilis during delivery if the baby is exposed to genital lesions. And vertical transmission actually increases the more advanced pregnancy is. So more commonly in the third trimester, but it can occur at any time in gestation. And vertical transmission is more likely with primary or secondary syphilis. And the clinical manifestations are most likely from the inflammatory response towards the infection. So when you consider a baby, if you're worried about congenital syphilis, always look at the placenta. And the placenta is often large, thick, and pale, and they can get a necrotizing punicytis. So that's inflammation of the umbilical cord, and it can look like this barbershop picture, which is characterizing by spiral stripes of red and blue discoloration of the umbilical cord. And just to remember with syphilis, if women are untreated and they have early syphilis, up to 40% of them will result in loss of the fetus with stillbirth or death. So just the features of congenital syphilis, it's the great masquerada, so it can affect almost any organ system. Here's the classical snuffles or rhinitis, and this is very infectious. They can get the rash, which often involves the palms and the soles, and then an osteitis. You can see the reaction there. This is Wimberger's sign, which is the metaphysitis of the medial aspect of the tibia. And infants may have a similar mucocutaneous rash that adults get with secondary syphilis. And if you see peeling hands and soles in a baby, you always need to think about congenital syphilis. We can mention the late manifestations, but most of us are not going to see this due to most children receiving some form of antibiotics in the first years of life. But they classically would get the prominence of the forehead, the saber shins, and these Hutchinson teeth with the mulberry molars, and then the saddle nose and interstitial keratitis. And so that can lead to blindness, and they can also get deafness. Congenital varicella syndrome is another extremely rare disorder, and it occurs in less than 2% of babies born to women who are infected between weeks 7 and 28 of pregnancy. And the risk of transmission is more common when the mom has the infection in the 13th and 20th weeks of gestation. And the characteristic features are going to be low birth weight, cutaneous scars, which are in a dermatomal distribution, the absence of skin on the limb, and hypoplasia of one or more of the limbs with malformed digits. There also are neurological defects, which can result in seizures, mental retardation, hydrocephalus, cerebellar aplasia, and cephalomyelitis. And the characteristic scarring may represent the cutaneous residue of the varicella zoster virus infection. And it's very similar to herpes zoster shingles infection. And the virus may select tissues that are in rapid developmental stage, for example, the limb buds, and that can result in shortened or malformed limbs. And congenital rubella is actually associated with a mortality of 30% in the first few months of life. And if a baby's had congenital rubella, they've got a good chance of developing herpes zoster in the first 4 years of life. So parvovirus is single-stranded DNA, and the fetus is especially susceptible to effects of parvovirus-induced anemia because it's got a shortened red cell half-life. And their relatively immature fetal immune system is less able to control the infection. So it usually, infection can result in miscarriage, or death, or in a non-immune hydrops. And on a sonar, you might see pleural effusions or ascites, and fetal death will occur in about 6% of pregnancies, and fetal death rate in women diagnosed with first trimester infection was 13%, going down to 9% for infections in the later pregnancy. And then Zika virus, the clinical features, you get microcephaly, the facial disproportion, and the features of cerebral palsy with hypotonia and hyperreflexia, seizures. And Zika is transmitted by the Aedes aegypti mosquito, which lives in tropical regions, but it can also be transmitted by Aedes albopictus. And these babies also get subcortical calcifications in the brain. All right, so it's all a bit confusing, but just I think to remember a few things for every organism. So for Toxoplasma, the triad of hydrocephalus, the diffuse, in the middle of the brain, intracranial calcifications, chorioamnionitis. For rubella, we're going to be thinking about PDA or PS, the hearing loss, cataracts, and CMV, looking for those periventricular calcifications that often are IUGR, have thrombocytopenia. HSV is the classical skin vesicles with associated neurological involvement as well. Syphilis is the classical rash with peeling of the palms and soles and rhinorrhea. And then you can always ask for a limb x-ray to look for osteochondritis. And then varicella zoster is the limb hypoplasia. And parvovirus is the hydrops fetalis. And HIV, babies we all know how they can present with severe thrush failure to thrive, and they classically have calcification of the basal ganglia. All right, so I'm just going to talk a little bit about intraamniotic infection, as chorioamnionitis is now preferred to be called. It's not called intraamniotic infection because it's realized that the infection is not limited to the chorea and to the fetal membranes. And it's actually acute inflammation of the membranes and placenta, and can also involve infection of the fetus. And it's classically a polymicrobial infection, and it has adverse maternal, fetal, and neonatal effects, and has increased long-term risks for cerebral palsy and other neurodevelopmental disabilities. And the treatment is antibiotic therapy and delivery of the baby. In 2015, the National Institute of Child Health and Human Development recommended that people now use the term triple I because this is quite a heterogeneous disorder. And the 3 I's stand for intrauterine, infection, or inflammation. So this terminology is not really being commonly adapted, but the criteria are being used. So if we look at classification of triple I, whenever a mother has a fever, you're going to document that, and they say a fever more than 39 degrees on any one occasion is a documented fever. Suspected triple I is fever without a clear source and any of the following. So you want a fetal tachycardia, maternal white cell count that's increased, or evidence of purulent fluid from the cervical os. And then confirmed III is when you actually look at the amniotic fluid and send it off, and you gram stain it for bacteria. You see that there's low glucose in it, and also the white cell count is high. And or you look at the placenta and membranes once the baby is delivered, and you see a pneumocystis or infection there. So choreoamnionitis occurs when there's migration of the cervicovaginal flora through the cervical canal. That's the most common mechanism of infection, but it can occur through hematogenous spread, and a classic example of that is listeria. And the common risk factors are longer length of labor, prolonged rupture of membranes, and then just to go through the clinical, the fever, maternal leukocytosis and tachycardia, fetal tachycardia, uterine tenderness, and then bacteremia or purulent or malodorous amniotic fluid. And then treatment is with delivery of the baby and broad spectrum antibiotics. When characteristic clinical signs are present, the condition is usually termed clinical choreoamnionitis. However, histologic choreoamnionitis, which is inflammation of the chorion and amnion, is 3 times as common as clinical choreoamnionitis and confirmed by amniotic fluid culture. So there are 2 main varieties of choreoamnionitis. There's acute choreoamnionitis, which we all think of when we think of choreoamnionitis, but there's also this entity of subclinical choreoamnionitis. And they differ both in the clinical manifestations and microbiology, but also in their risk to the fetus. So acute choreoamnionitis is strongly associated with early onset sepsis, but the subclinical variety is actually thought to contribute to a risk of chronic lung disease and brain injury. And a lot of children who were diagnosed with birth asphyxia or cerebral palsy from problems at delivery might actually have had subclinical choreoamnionitis. And regardless of gestational age, the genital mycoplasmas, which are ureaplasma and mycoplasma, are the most common organisms isolated. Because they're highly prevalent, they're more than 70% in the lower genital tract, some people thought that their isolation was just contamination or colonization from the lower genital tract rather than true infection. But I think more and more evidence is coming to support that they can be pathogenic, and they induce a robust inflammatory response, which has quite significant clinical consequences for both the mother and the baby. And other pathogens frequently associated with intraamniotic infection include anaerobes such as Gardnerella, Bacteroides, your enterogram negatives such as E. coli, and group B Strep. And so despite a lack of overt symptomatology, when investigators took a bit of amniotic fluid from mothers who were asymptomatic at 16 to 20 weeks of gestation, they saw that there was ureaplasma there, and those babies often had adverse pregnancy outcomes such as fetal loss and preterm birth compared to mothers who had sterile cultures. So if we look at the choreoamnionitis, it results both in maternal and fetal inflammation. I like the term FIRS, so fetal inflammatory response syndrome, and that results in the release of lots of cytokines, which can cause fetal and neonatal brain and multi-organ injury, which results obviously in perinatal death and long-term morbidities. But also this inflammation results in preterm labor with all those consequences, prolonged premature rupture of membranes, and then premature preterm birth, not primary TB. All right, so I think for me, this was quite a new thing. I didn't really understand this, but it shows that we need to continue to find out how do we promote a healthy vaginal microbiome, and why do some moms get abnormal colonization of the lower genital tract, and then to explore, are there any anti-inflammatory therapies we can give to these moms to improve outcomes for these mothers and babies. And then one of the organisms I just wanted to talk about briefly, that's commonly involved in Choreoamnionitis, is group B Strep. So this is the gram-positive streptococcus, and it commonly colonizes the GIT and genitourinary tracts. And while most pregnant women are completely asymptomatic when they colonize, there can be adverse effects on the mom. So the mom can get septicemia, mastitis, urinary tract infections, choreoamnionitis, postpartum endometritis, miscarriage and preterm labor. But the effects on the fetus and the neonate can be absolutely devastating, such as stillbirth, prem labor, pneumonia, meningitis, early onset sepsis, so within the first 7 days of life, or late onset sepsis. And increasingly, we're realizing that group B strep infection has quite significant neurodevelopmental impairment outcomes on babies. And GBS is a leading global cause of neonatal sepsis and meningitis in infants less than 3 months, and the highest burden of disease is in Southern Africa. And, globally, estimated 18% of women have rectovaginal GBS at the time of delivery, but up to 25% of women can be having GBS at the time of delivery. And it's also thought to contribute quite a bit to stillbirths. So up to 4% of all stillbirths in Africa are due to GBS. And it's also one of the reasons that moms go into preterm labor. So if they colonize with GBS, they're 1.8 times more likely to go into preterm labor. So how do we screen and prevent? So group B strep, there are either 2 screening protocols: universal screening, which is done in the US, but not in South Africa. And that's at 35 to 37 weeks of gestation, 3 to 5 weeks before the expected date of delivery. You get a high vaginal swab, which is sent then for culture. If that's positive, then you're going to give intrapartum antibiotic prophylaxis. So that's a universal screening, but the risk-based screening is what we should be following in South Africa. It's not always very well done. So women should receive intrapartum antibiotics if they're in preterm labor, if they have ruptured their membranes for more than 18 hours, if they have a fever, or if they have documented GBS bacteria in this pregnancy, or a previous child born with invasive GBS disease. So, globally, 21 million pregnant women are infected with GBS, and 1 in 5 of all pregnant women. Most are untreated and unidentified. And you can see sub-Saharan Africa has the biggest amount of women with GBS. And as we said before, it can result in bad consequences to the fetus and to the mother. And I think there've been a lot of articles recently from South Africa looking at associations between different parts of it. So neonatal encephalopathy, which is the new term ready for birth asphyxia, so babies who are born with signs of, there's brain damage. And the hypothesis is that infection causes the immature brain to be more susceptible to perinatal events. So they can tolerate far less hypoxia than a baby who doesn't have an infection. And this increases the risk of neonatal encephalopathy. And so in probable confirmed sepsis was identified in up to 18% of all moderate severe NNEs in South Africa. And if a child was shown to have GBS as well, there were much higher case fatality rates compared to children with NNE without sepsis. And then a recent study from South Africa, this was done in 2022, compared neurodevelopmental outcomes in children who survived invasive GBS disease to non-infected children. And these children were 5.5 times more likely to have moderate or severe neurodevelopmental impairment at 5 to 8 years of age than non-invasive GBS children. So this is just a nice diagram to show you, if a mom is colonized for her own health, she can result in a healthy mother, or she can get sepsis and she can recover from that, or she can have impairment from it, or she can die. And it can result in preterm death, preterm births, and then early onset neonatal sepsis or late onset neonatal sepsis. And these all have, risk of the child or the mother dying, but also of significant neurological impairment. So in HIV positive women, maternal colonization with GBS is similar, in HIV positive and HIV negative women, but the risk of invasive disease from GBS is much higher in HIV exposed, even uninfected infants compared to HIV unexposed infants. And that's especially important for late onset disease. So with group B strep, with late onset disease, that's disease manifesting after a week of age, intrapartum prophylaxis does not prevent those children from getting infection. And so, the theory is that there is lower serotype-specific maternal antibody transfer to the babies to protect them against GBS infection. So there are strategies, there are thoughts about what we can do to try and, prevent preterm deliveries, to prevent stillbirths, and to improve outcomes in babies. And, intrapartum antibiotics is going to prevent early onset neonatal sepsis, but unfortunately, antibiotics given to the mom are not going to make much difference to outcomes in that pregnancy because the mom will just be recolonized with it. So the idea, how can we prevent both early onset and late onset GBS disease? This would be the development of a vaccine. And so a maternal vaccine for GBS should be developed, and WHO has recognized this and say, the global burden of GBS is much higher than previously recognized. And there's an urgent need to develop a GBS vaccine. At the moment, there are only phase 2 studies that have been done. There are 2 main approaches for GBS vaccine development. The one that's been studied in South Africa, and the most common approach, is a multivalent capsular polysaccharide protein, which is conjugated. The one in South Africa, there were 2 GBS serotypes, and it can be conjugated either to, diphtheria toxoid or tetanus toxoid. But there are also protein subunit vaccines that are being developed. So really, we urgently need to look at more ways of improving outcomes for babies. So in conclusion, I think we must all remember the common things first. HIV, TB, and sepsis are the #1 cause of maternal morbidity and mortality. We want to encourage moms to know their HIV status before they fall pregnant, to be on ARVs and fully suppressed before they conceive. And in that way, we can prevent a whole lot of the opportunistic infections that are causing them to die. Remember, prevention is always better. We want to vaccinate our moms. You want to vaccinate them for rubella, chickenpox, and measles before pregnancy, because those are live vaccines. You want to and you want to make sure that they are protected against influenza, COVID-19, and tetanus and pertussis. And don't upset your friendly Peds ID doc. Never ask for a touch screen. Or if you do, it can be quite entertaining. Just stand back and watch the reaction. And then we should be doing a much better job of screening and antibiotic prophylaxis for group B strep prevention. So, every delivery, please make sure to give antibiotics if it's indicated at a minimum. I do have a few MCQs. I don't know if we want to do them.
Yeah, sure. Let's do it.
We can do. So they're not very difficult, but I'll just give you one. I've got a 10-month-old baby boy got developmental delay and microcephaly. He's got a PDA and a cataract. So what is the most likely diagnosis? Is it, sorry, it should be A, congenital CMV, B, congenital toxoplasmosis, C, congenital rubella, or D, congenital herpes. Okay, so we have.
So they can't see the results yet. You can, but we'll give them another 10 seconds and then I'll release the poll to everyone. We have a clear winner anyway. Maybe we say right, I'm sharing results.
I'm glad people were listening. Yeah, I think, yeah, congenital rubella. So the clue is the cataracts and the PDA. Yeah, well done, everyone. A 2-day-old girl, SGA, hepatosplenomegaly and jaundice, got thrombocytopenia and periventricular calcifications. So is it A, congenital CMV, B, congenital toxoplasmosis, C, congenital rubella, and D, congenital herpes?
I think you've stacked the audience, Jill.
Yeah.
All right,
So
I'm
I'm
going to
glad
share
I
results.
just want, yeah. Okay. Cool. So yeah, congenital CMV, and I think the clue is the periventricular calcifications with IEGR microcephaly. And then I'm sure you can all guess this one. 3-day-old boy, he's got macrocephaly, intracranial calcifications, and hepatosplenomegaly. So what is the most likely? A, congenital CMV, B, congenital toxoplasmosis, C, congenital rubella, or D, congenital herpes? So it does get easier and easier. Process of elimination. Okay, so that is congenital toxoplasmosis. Cool, and that's all I have for you.
That's great, thank you. And you clearly did a great job because of the poll results at the end. Fantastic. lots of great comments and lots of appreciation. So thanks, Jill. It was a really lovely overview. I like the beginning as well, where you kind of put it in context from biological and evolutionary perspective. I'm looking at some of the questions that are coming through. Lauren's asking about the subclinical chorioamnionitis. So is there any way to suspect this? I know it's subclinical potentially, but is there anything else? And for example, would screening help maybe as well in terms of screening, say there's a cervical region or something for some of the pathogens, or has that not really been associated with benefit?
Yeah, so I'm afraid I don't know that much about it. From my understanding, is because ureaplasma and mycoplasma are actually so common in your vaginal microbiome, it doesn't always correlate. What they've done though is they have sequenced the microbiome using PCR, and there is a certain look to the microbiome that is more likely to be a dysbiosis. But the only way that I can see to pick it up really is to do the intraamniotic fluid and look at it.
Sure. And
but it's all new to me, I must admit.
Okay.
I don't know.
Yeah, a point well made. And then Remco's asking about the hepatitis B surface antigen screening, given that it's done in other countries and we have a relatively high prevalence, obviously, of Hep B in South Africa. Is that something that's on the cards, or what would your view be on that? Yeah,
so I think in South Africa, what we do, we vaccinate for Hep B at 6 weeks of age. So we'll be missing quite a lot. I think the way we're going is to make sure everyone's vaccinated, and by that, it would be nice to screen with Hep B surface antigen, but in terms of cost effectiveness, I think what would be more beneficial would is also to change it to a birth vaccine of hepatitis B. But I think the thought is because we're vaccinating everyone, we are hoping that they'll grow out of it. I think in South Africa, we don't have as many women who are Hep B E antigen positive, and they're more likely to transmit hepatitis B. But obviously in an ideal situation, we should be screening for hepatitis B. And especially there's more evidence coming out now that you can treat them with Truvada in pregnancy. I think there was a study done that showed that it had good outcomes.
Yeah, it's interesting. So it's just a cost consideration, I guess. I mean, as you say, I mean, have you started to see a decrease in maternal hepatitis surface antigen positive people because of the vaccine starting?
No, I don't think so. I think also we're not looking a lot.
Okay, yeah, I guess it's not routine, yeah.
Yeah.
Okay, interesting. And then one question someone WhatsApped to me was, whatever happened to Zika? If you want to go,
yeah.
take that on.
I think that's the point they're trying to make, is that if you get Zika infection before you fall pregnant, you're not going to have these. And so most people have got it, and it's probably still around. There will still be people getting Zika, but it's not this epidemic, I think.
Yeah. I mean, as you say, once it's ripped through the population already and they're immune, the new infections are mostly kids, without, before they can fall pregnant, which makes a big difference. I mean, I don't know if there's another explanation. I mean, there's certainly, as far as I know, there is certainly a lot of infection still going on in South America, for example, in Brazil. But as you said, the congenital Zika is largely vanished. And I think, as you said, it ripped through the country, found everyone who, in a new population. And then since then, doesn't seem to have been causing a big problem. Touch wood, we've learned from viruses in the past few years that when you think you've seen the back of them, they might come back with a new variant. But hopefully not. I see Colleen Bamford's written about, also to add to your torch screen, that microbiologists don't react well to urinary group B antigens testing requests. So I think point well made there too. Yeah, I think that's it for the questions. Thanks very much, Gill. That's fantastic. Really, really nice overview. And a big topic, in which you've covered really, really nicely. So thanks very much.